So good morning, everyone. I'm going to be talking today about viral hepatitis. Whenever I think of hepatitis B, it always makes my brain hurt. And especially hepatitis C when I was studying for the boards, all the medications. So it's one of those things where, it's very important to know, but it's not always the easiest concepts to figure out. So I'm hoping I'll make this a little bit easier for you all. So we'll be going over hepatitis B, hepatitis C, hepatitis E, and hepatitis A. So we'll start off with hepatitis B, probably everyone's least favorite. So it's a partially double-stranded virus. Chronic hepatitis B versus acute infection is marked by the presence of the surface antigen for at least 6 months. At that point, you can then say it's chronic. The presence of the surface antigen establishes the diagnosis. Prevalence varies greatly between countries, and it can be transmitted perinatal, percutaneous, sexual exposure, and close person-to-person contact. But the most important cause of chronic infection, but perinatal is the most important cause of chronic infection in endemic areas. We see this a lot in Asian countries. The highest prevalence of chronic hepatitis B is in China and Magnolia. Many other countries in Asia as well. In the U.S., immigrants from these countries account for about 50% of all chronic infections. Within the United States, African Americans have the highest prevalence. So for screening, you want to screen everyone who's been born in regions of high or intermediate hepatitis B and endemism from those countries. I will say in all of our patients who have, chronically elevated liver enzymes, we screen for hepatitis B. So this is kind of a moot point. You can also, full list, I'll let you guys read that all on your own, but in my practice, if they have elevated liver enzymes, I'm going to be looking for hepatitis B, and especially to see if they're immune or not immune. Characterization of an individual's hepatitis B status can be achieved with 3 tests. You have your surface antigen, which is indicative of hepatitis B infection. You have your core antibody, which signals prior exposure. And you have your surface antibody, which signals immunity to the infection. So those are the 3 most important tests. Chronic infection is confirmed with the surface antigen and or the DNA. And in all these patients, you want to check for hepatitis D as well. Diagnosis of acute hepatitis B is by the positive IgM hepatitis core antibody, as well as the surface antigen. And this usually we'll see, in the acute setting with liver enzymes in the thousands. Unlike hepatitis C infection, Hep B is more commonly associated with signs and symptoms of hepatitis. So, they could be jaundice, may, have swollen their liver, hepatomegaly, some discomfort from there. So this is a nice tool I created several years ago, actually, when I was a fellow. I'm not going to run through it all, but at least you guys will have it in your presentation. But it's kind of a way to test yourself. I'll just kind of hit the key points. It shows, so if you have your core antibody positive and surface antibody positive, surface antigen negative, that's immune due to a natural infection. You had the infection and you self-cleared it. If you had a hepatitis B vaccination, you should expect to see the surface antibody positive, but your core antibody and surface antigen are negative. Now, the window period of acute hepatitis B, that will be marked by just your positive IgM anti-hepatitis B core antibody. That will be positive. Your surface antibody and your surface antigen are negative until you become acutely affected. That's where you gain your positive surface antigen. And then chronically infected, you'll see the surface antigen and the core antibody positive, and you won't see the IgM at all. So natural history of hepatitis B. So we used to priorly say, you had your immune tolerance stage, your inactive carrier, and I have another slide on the next one to help kind of explain this. We're kind of moving away from those nomenclatures, and now we have just hepatitis E antigen positive or hepatitis E antigen negative. So you'll, at some point, you have your E antigen is positive, you can lose the infection, and that'll kind of take you through your pathway. All of them can lead to liver injury as well. It's a little bit easier to see on here. So like I said, now instead of the immune tolerant, the immune reactive, E antigen positive, inactive carrier, or the E antigen negative chronic hepatitis, we're kind of moving away to either, first you want to look at, is your E antigen positive or is it negative? If your E antigen is positive, then it's either you either have a chronic HBV infection or chronic hepatitis B. With inflammation, liver enzymes increase, and that's when we call it hepatitis, itis, inflammation. There's no inflammation, liver enzymes are normal, then it's just the chronic hepatitis B infection. So for chronic hepatitis B, either E antigen positive or E antigen negative, your ALT will be elevated, and your DNA will also be elevated as well. That's the key point, is the elevation in your ALT. Same thing for E antigen negative. So as I said before, you have to have your surface antigen positive for at least 6 months to consider it chronic. Patients could either have normal or elevated liver enzymes. Your HBV DNA can range from barely detectable to hundreds of thousands. Each patient's different. Liver biopsy will show chronic hepatitis with variable necroinflammation and or fibrosis. And then, as I said before, we divide it into E antigen positive, hepatitis, or E antigen negative. HBV DNA levels are typically greater than 20,000 in E antigen positive chronic Hep B infection. Lower values are often seen in E antigen negative. So this is for your hepatitis E antigen positive, just your chronic infection that's tolerant of the hepatitis B by the host immune system. You'll have very high levels of DNA, but a no immune response against the virus. Your E antigen will be positive. Majority of these patients are Asian who acquired hepatitis B at an early age. Usually they don't develop progressive liver injury, fibrosis, or cirrhosis, and should be monitored for serological activation, that marker where your liver enzymes become elevated and you move more into a hepatitis-like picture. E antigen negative, again, your surface antigen is present for 6 months, your E antigen is negative, your E antibody will be positive. DNA is usually less than 2,000. Usually you'll have persistently normal liver enzymes. And liver biopsy confirms the absence of significant necroinflammation with variable levels of fibrosis. So a simplified version for treatment. So it determines your first step, are they E antigen positive or the E antigen negative? If they're E antigen positive and your ALT is normal, they don't recommend treatment. Even if you have high levels of HBV DNA. Now, if your liver enzymes are elevated, ALT is greater than 2 times upper limit of normal, then recommend treatment when the HBV DNA level is greater than 20,000. Now, if their DNA is elevated, but the liver enzymes are normal, again, you don't need to treat, but what you want to do is you want to monitor these patients every 3 to 6 months, as to check their labs, see if they've converted, make sure their liver enzymes are, staying normal. AASLD does not recommend this at this time, but you can consider, treating for HBV DNA levels greater than 2,000 to prevent HCC, but again, that's not fully endorsed by the AASLD at this time. E antigen negative, our threshold is 2,000. So if your DNA is greater than 2,000 and your liver enzymes 2 times upper limit of normal, that's when they recommend treatment. And again, regardless, if your DNA is greater than 2,000, your liver enzymes are normal, then they don't recommend treatment, just continued monitoring. So these are the main medications that we use anymore. There's some other ones that are available, but I kind of left them out because these are the important ones. You have entecavir, tenofovir, TDF, and then tenofovir alafenamide, TAF. Important to note that if you look at the pregnancy category, the TDF is B, and that's what's recommended in pregnancy. Now, all of these, medications don't come not without risk. So while they're on, while they're getting treatment, for all three of them, you want to check lactic acid levels if there's clinical concern. You also want to test for HIV before starting treatment in all the patients. And then for the TDF, you can consider getting a DEXA at baseline and during treatment at patients who are high risk for osteopenia. So patients in certain populations, so if they're compensated, cirrhotic, they have low-level viremia, it doesn't matter. You want to treat regardless of the ALT level because you want to try to prevent them from decompensating. There's no recommendations on optimal length of therapy. Usually I just keep the patients on them. Now, if they're decompensated cirrhosis, you want to treat regardless of HBV level, E antigen status, or ALT, and that's indefinitely. Pregnancy, TDF is the preferred agent. You start it at 28 to 32 weeks if the HBV DNA is greater than 200,000. You want to stop at birth or at 3 months. If they don't have any other indication to continue, then you can stop it. Breastfeeding is not contraindicated. The infants need to receive the hepatitis B immunoprophylaxis, and in the mother, just continue to monitor their liver enzymes. And for patients who are for HCC screening, you want to screen all patients with cirrhosis. And patients without cirrhosis and who are high risk, you do start screening. So this is our Asian or Black men greater than 40 years of age, Asian women greater than 50 years of age. If they've had a first-degree family member with history of HCC, you need to screen them as well. If they're hepatitis D positive, screen. And if they're born in Africa, I usually start screening around 20 years of age or when they first come in because there's a higher prevalence of developing HCC in those populations. Again, you can use the recommendations ultrasound with or without AFP, Q6 months. You could also, alternate with MRI as well, but the guidelines say ultrasound. So likelihood of liver failure from acute hepatitis B is less than 1%. And actually the risk of, and the progression to chronic liver disease is only less than 5%. Where the only times that's, where the increased risks you get to continuing having issues if you're immunocompromised, have concomitant infection with hepatitis C, HIV if you have pre-existing, liver disease like MASLD. Indication for treatment in the acute setting, this is just for acute liver failure guidelines. Your INR is greater than 1.5. Marked jaundice for more than 4 weeks after presentation. Use tenofovir and entecavir. This is, for in the acute setting if they're really sick, and you don't necessarily have to wait till they reach that 6 months mark. You want to start, treatment now. All right, that was hepatitis B. We'll now move on to hepatitis C. It was first identified in 1989. It's a member of the Flaviviridae family. There's several genotypes 1 through 8. It's, exposed parental exposure, IV or intranasal drug use, blood transfusions prior to 92, needle sticks, tattoo body piercings, high-risk sexual contact. About 130 million people are infected worldwide. 10%, only 10% are aware of their infection status, and only about 15% are treated. Within the US, it's 3 million people. 50% is actually aware, but only 10% have received treatment. The World Health Organization, their goal is to eradicate hepatitis C by 2030, which we easily can do because we have such a increase in amount of medications that are available to use. So most of the times, you think about your baby boomers, 1945 to 1965, but as you can see here, even in the subsequent generations, hepatitis C is still happening. So it used to be that we only screened patients, in the baby boomer range from 1945 to 1965, but now they recommend a one-time routine opt-out hepatitis C screening if you're 18 years or older. And then you can do periodic testing if they do have risk factors or exposure as well that are continuing. You want to do annual testing for persons who inject drugs, men with HIV positive, and having unprotected men who have sex with men. The screening test is hepatitis C antibody. False positives can occur about 5% of cases, as high as 30% among individuals without risk factors. It's why it's important to take into account their history and see if they actually have any high risk features. Confirmatory test is the RNA. If your hepatitis C antibody is positive and your RNA is negative, that means two things could have happened. It was a false positive, or they were exposed and self-cleared the infection on their own, or they had previous treatment. But you need to get that RNA before you can definitively say if someone has hepatitis C or not. For any patient, if you're starting treatment, you want to do a cirrhosis assessment. Patients are assumed to have cirrhosis if they have any of the following present. So you can use FIB-4 scores, transient elastography, other non-invasive serological tests, clinical evidence of cirrhosis, so just by like a liver nodularity, their platelet count, or if they've had a prior liver biopsy. You don't necessarily need that liver biopsy. From any of those, you can say that the patient is cirrhotic. You want to perform, medication reconciliation, look for drug-drug interactions. So within 6 months of, initiating treatment, you want to get basically your MELD labs, your CBC, your renal panel, your hepatic function panel. At any time before starting, of course, they're going to need the HCV RNA level. You want to test for hepatitis B, screen for that, as they may need, treatment coverage for that, and HIV testing. Before initiating antiviral therapy in patients, of childbearing age, you want to get a pregnancy test. Like patients starting on Tuesday, we'll get the pregnancy test on Monday. I actually had this happen before where we're starting treatment on a patient. We sent her for a pregnancy test, and we told her she was pregnant. She had no idea. They weren't really trying, so we delayed treatment at that time. On treatment monitoring, if they're taking diabetic medications, monitor for hypoglycemia. If they're taking warfarin, you want to monitor INR for subtherapeutic anticoagulation. But otherwise, there's no lab monitoring on treatment for any other patients. Your post-treatment assessments, so you want to check your HCV, RNA, and hepatic function panel 12 weeks or later following completion of therapy. If their HCV RNA is 0, then you can say that the hepatitis C has been eradicated and they've achieved SVR. If for patients who don't have any other liver conditions or anything, once you say they're good to go, they don't need any more hepatology follow-up. The only patients who do are those who have ongoing risk factors. You want to make sure you counsel those patients about those risk factors, and you want to test for hepatitis C RNA annually and with elevated liver enzymes. And you, of course, avoid excess alcohol use. They've already had one insult to their liver. You don't want to have another one. So the treatments. So for the DAA therapies, the protease inhibitors, they end with Previr, and they start with a P. You want to avoid these in decompensated liver diseases. We also have the replication assembly NS5A inhibitors, Aspir. They all end with Aspir. They start with an A. Specifically for these, you want to watch for NSA5A resistance associated substitution. And then we have our NS5Bs. These end with Buvar. They start with B. For these, drug-drug interactions with amiodarone can cause bradycardia. In ribavirin, you want to avoid renal impairment, anemia, and pregnancy. And again, just a quick cheat sheet, which is kind of helpful for boards or just learning how to identify which they are. They're protease inhibitor, they're NS5A or NS5B. So there's several available therapies on the market. You have Mavyret, which is pan-genotypic. You can use it in any genotype. Epclusa, also pan-genotypic. You can use it in any genotype. It does require NS5A RAS testing in genotype 3 patients, though, with cirrhosis. Vosevi, again, pan-genotypic, and this is what you want to use for prior therapy, like prior DA treatment failure. So say they've tried Mavyret before and they didn't, 12 weeks passed, they still have the RNA. This is when you'd want to use Vosevi. We get into Harvoni and Zepatier. Those are genotypic specific. So it is important in those cases to get the genotype if you want to use those. And you can add weight-based ribavirin in patients with cirrhosis. All right, moving on to hepatitis E. We just have E and A left. So hepatitis E is a small spherical virus icosahedral capsule that is quasi-enveloped. The virus is naked environment while being shed in feces. The envelope virus will circulate in the blood. Single-stranded, positive sense RNA genome. There's 4 different genotypes that infect humans. You have your HEV1, which is endemic to Asia and parts of Africa, and then HEV2, which is endemic, but is pretty much restricted to Africa and Latin America. These only infect humans, and they are waterborne, so it can lead to large outbreaks locally if it does occur. Hepatitis E, the 3 and 4, that's sporadic. Usually from animals, affects a wide range of mammals, particularly pigs. Hepatitis, the 3rd genotype, is widely dispersed. Hepatitis E4 is most common in East Asia. So acute infection, the incubation period is about 40 days. You can have range of symptoms from being asymptomatic, you're completely okay, maybe not even know you have it, to fulminant hepatitis, which has about a mortality of about 1%. It can, the other ones, there's no evidence of chronic infection with hepatitis with genotype 1 and 2. However, number 3 can lead to chronic infection. This is in your immunocompromised patients. So those who've had solid organ transplants, your HIV patients who maybe not treated, they have low CD4 count, and patients with cancer or receiving chemotherapy medications. So hepatitis E, you most worry about this in pregnant patients. It can cause acute hepatic failure with a mortality rate of 20 to 25%. Typically, if it does occur, will be in the 3rd trimester. I myself have not seen this personally. And then extrahepatic, so it can affect your neurological as well as your kidneys. And for neurological, you can get like a Guillain-Barré syndrome, neurologic amyotrophy, and meningoencephalitis. And that can happen about 8% of infections. So treatment, if they've had that solid, if they've had a solid organ transplant or they're on chemotherapy, you can reduce the immunosuppressive therapy. The calcineurin inhibitors, so tacrolimus, promote hepatitis E virus replication. Your mTOR inhibitors, everolimus promotes hepatitis E replication. But the one point to note is out of the immunosuppressive medications, myclophenolic acid inhibits the replication. There's been limited evidence of using pegylated interferon. It can increase risk of organ rejection in those who've had solid organ transplants. And then they've tried ribavirin, and small groups of patients have been successfully treated. Last one, hepatitis A. So it's a non-enveloped, small, single-stranded RNA pecanovirus. It replicates within the hepatocytes. It induces an immune response, which leads to inflammation and interferes with hepatic function. Transmission is via the fecal-oral route. Usually it's acute, self-limiting, infection. Patients can get fever, nausea, abdominal pain, jaundice. Only about 0.1 to 0.2% of active cases can lead to acute liver failure. So, this is lower on your differential if you have a patient coming in with acute liver failure. The vaccine came out in 1997, and the prevalence of this has dropped significantly to more than 90%. So, we're not seeing this as much anymore with patients who are getting vaccinated. However, worldwide, there's 1.5 million cases. You can see it's mostly, everywhere else in the world minus the United States. Actual infection rate is likely 10 times higher. That's just not reported. So weeks, as you're exposed, your ALT can rise. That's usually when the acute phase, and then your ALT will decrease. At that time, there will be a transition point where you're going from your IgM, anti-hepatitis A virus, to your IgG, and they're getting immunity. Wide range of symptoms, most commonly dark urine, jaundice, loss of appetite. This is just for screening and testing. If you have a suspected patient with hepatitis A, if they've had the HIV IgM assay on the right, if it's not reactive, you can report not detected. If your IgM is positive, it's reactive. Do they have a clinical picture, consistent with hepatitis A? If so, you can report detected, and it's consistent. However, it could just be an incidental finding. It's not the only thing going on, so just think of that as well. The clinical picture may not fit. Treatment supportive, those with acute liver failure, you can try NAC. You want to transfer to a liver transplant center right away. Patients may have a prolonged recovery, sometimes greater than 3 months. You can also get relapsing hepatitis. So you'll be doing well, and then basically it'll relapse and you'll have it again. You lose your IgM, but then it becomes positive again, and you can have a protracted cholestatic hepatitis where you'll see the elevated bilirubin, and there'll be jaundice for long, and it'll take a while for that delta bilirubin to decrease. So prevention, hepatitis A vaccination. If you're less than 40 and you're traveling internationally, you want to get it regardless of your scheduled date of departure. Hepatitis A vaccination plus immune globulin. This is recommended in older adults, immunocompromised individuals, those with chronic liver disease or other chronic medical conditions who are traveling within 2 weeks. And then, of course, you want to do food and water precautions. All right, so that's pretty much it. We kind of went over kind of a lot. Remember, for the pregnant patients, you want to treat if their DNA level is greater than 20,000. You want to remember your DA therapy contraindications for hepatitis C. You want to avoid your protease inhibitors and decompensated cirrhosis. You want to test for NS5A RAS in previously treated patients. Watch for bradycardia in patients with sofosbuvir who are using amiodarone. There's 2 different types of hepatitis E virus. It can be really increased mortality rate if one does get it. And then again, hepatitis A is spread oral fecal. All right, thank you.